So we move on to the anterior inferior cerebellar artery syndrome, and now we're looking at the lateral pons, right? So when we look at the lateral pons, let's try to understand the areas that are affected by the anterior inferior cerebellar artery. All right. So the things we're losing here are basically the facial nucleus. I can't appreciate the facial nucleus on this image. And then we're losing the vestibular nuclei. The vestibular nuclei also I cannot appreciate. Um, Then we're losing the spinal thalamic tract and spinal trigeminal nucleus that I can see. So you can look at the spinal trigeminal nerve here, and then the nucleus here, the chief sensory nucleus of spinal trigeminal tract is here. The motor nucleus of trigeminal tract is here, right? So you can see they're both on the lateral pons, and then we also are losing the spinal thalamic tract, right? So the spinal thalamic tract, can we see it here? No, not really. I cannot see the spinal column tract here, right? Okay. And then some middle and inferior cerebellar peduncle. So this is the middle cerebellar peduncle. If you look at this is the section of the upper pons. If I go to the lower pons, I will also be able to see the inferior cerebellar peduncle. We're losing that too. And also there's a labyrinthine artery that also I'm losing. Um, okay, so this is another picture I've taken out. Can you see the facial colliculus here? The facial colliculus is here. The facial nerve is here, right? Here, this is the facial nerve, and it's looping around the abductor nucleus, which creates this bump, and we call that bump the facial colliculus. So this is the nucleus of the facial nerve, which we were talking about. This is the lower pons, right? So this is the inferior cerebellar peduncle. We're also losing the inferior cerebellar peduncle. We're losing the vestibular nuclei. So these are the two vestibular nuclei. One is here and one is here. Um, Again, the spinal nucleus and tract of the nerves is also something we're losing, and the spinal thalamic tract itself. That also, again, I cannot see here. The labyrinthine artery also, I cannot see on this section. So here we've looked at the structures that we're losing, right? So we're losing the facial nucleus. Since we're losing the facial nucleus, we're getting paralysis of the face, right? You know that the lower motor neuron lesions affect the forehead and the lower face, but the upper neuron lesion will always spare the forehead, right? So there's decreased lacrimation, there's decreased salivation, and there's decreased taste from the anterior two-third of the tongue. This is all because we're losing the facial nucleus, right? And then there's it's because of the vestibular nuclei being lesioned, we're getting this vomiting, we're getting vertigo, which is basically your loss of balance, and nystagmus. And then because of the spinal thalamic tract, the spinal trigeminal nucleus being lost, we're getting loss of pain and temperature sensation from contralateral body and ipsilateral face. Sympathetic fibers being lost again is giving us the ipsilateral Horner syndrome. The middle and inferior cerebellar peduncles, you're cutting off the pons from reality of the cerebellum, so you're getting ipsilateral ataxia, dysmetria, and the labyrinthine artery gone is giving us ipsilateral sensory neural deafness and vertigo. Right, so since this is the lateral pons, you can see how this is all of the lateral pons, right? Can you see the lateral pons being affected here? So that's why we call this, what do we call it? We call it the lateral pontine syndrome. This is the lateral pontine syndrome. The facial nucleus effects are specific to anterior inferior cerebellar artery. Facial droop means anterior inferior cerebellar artery is pooped. That's a little mnemonic for you to remember. Also supplies middle and inferior cerebellar peduncles, which are part of cerebellum. Again, okay, so moving on to the basilar artery. The basilar artery is here. I told you that the two vertebral arteries combine to form the basilar artery, right? And the basilar artery then goes up to give you the superior cerebellar artery and the posterior cerebral artery. So if the basilar artery is gone, what are you losing? You're losing the pons, medulla, and the lower brain, lower midbrain, right? So if you're losing this, you're losing the pons, you're losing the medulla, and you're losing this upper part of the midbrain also, right? Uh, Okay, if the reticular formation is spared, the consciousness is preserved. What does this mean? Reticular activating system is found in the reticular formation, right, in the core of the upper brain stem. This inputs from every sensory system, and loss of this reticular activating system is basically a coma state of complete unresponsiveness to arousal in which the patient lies with the eyes closed, right? So if the RAS is spared, consciousness is preserved, otherwise no. Okay, we losing the corticospinal, the corticobulbar tracts. The corticobulbar is the face part of the corticospinal tract. So you're getting quadriplegia. There's loss of voluntary facial expression, mouth, tongue, movements, everything, right? And there's ocular cranial nerve nuclei being involved. So you're getting loss of horizontal but not vertical eye movement, right? And then there's paramedian pontine reticular formation also being lost, right? So this is all of the locked-in syndrome. We call this the locked-in syndrome. The basilar artery is called as the locked-in syndrome. What are you getting? You're getting quadriplegia, you're getting loss of horizontal but not vertical eye movement because you're losing all of it, right? You're losing facial, mouth, tongue movements. So you basically this is a locked in the basement syndrome, right? Um, then we have the posterior cerebral artery. I just showed you the posterior cerebral artery. This is the posterior cerebral artery. It's coming off of the basilar artery here. When you lose the posterior cerebral artery, you lose the occipital lobe. So you get contralateral hemianopia with macular sparing, right? This is it. Also, what else you get? You get alexia without agraphia in the dominant hemisphere. Just one thing, why did we call this the locked-in syndrome? Because you know what the patient is like? The patient is basically fully awake. He can think, he can hear, he can understand, but he cannot move his arms, cannot move his legs, cannot speak. Only vertical eye movements are preserved because the midbrain is intact. So the mind is trapped while the consciousness remains. It's a very, very painful kind of a situation where the patient can't really do anything. It's very helpless, sorry. Posterior cerebral artery, again, I told you it supplies the occipital lobe, the visual cortex, and symptoms are contralateral hemianopia with macular sparing. Why is the macula spared? The macular cortex often receives dual blood supply from both the posterior cerebral artery and branches of the middle cerebral artery, so central vision survives. The dominant hemisphere posterior cerebral artery can produce alexia without agraphia. What does this mean? Alexia without agraphia. Agraphia basically means can patient can write. Agraphia means to write, right? That means the patient can write, but alexia he cannot understand, right? He cannot understand. He can write, but he cannot read, even when they themselves have written. Even if they're writing themselves, they cannot understand what they've written, right? This occurs because the visual cortex is disconnected from the language dominant hemisphere while the language areas themselves remain intact. So since the visual cortex is disconnected from the language areas, but the language areas themselves are working, so that's why the patient cannot read what they have written, right? Then there's a central post-stroke pain syndrome. And what is this basically? This is usually after thalamic infarction. Initially, there's numbness, but weeks later, there's a burning pain. So first you just have numbness. Initially they're just paresthesias, followed in weeks to months by allodynia, which is ordinary painless stimuli causing pain. Like there's no stimuli, but there's pain, right? There's burning pain. Allodynia is basically pain from light touch. So you just give you a little, someone just touches you a little bit and you say, oh my God, this is so painful. And then this is aesthesia. This is abnormal, unpleasant sensation, right? On the contralateral side, occurs in 10% of stroke patients, right? Even my shirt touching my arm hurts. The patients may say something like, even my shirt touching my arm hurts. Now we have something called as a diffuse axonal injury. This is not really a stroke. It's caused by rapid acceleration and deceleration injury, like a high-speed motor vehicle accident. So there's this traumatic sharing forces during rapid acceleration or deceleration, right? Uh, because like this sudden brake or some examples of motor vehicle accident usually results in devastating neurological injuries, often causing coma or persistent vegetative state. That's really sad, right? The sharing of axons in the white matter. On the MRI, you see multiple punctate hemorrhages. Clinical picture will show you a coma and a persistent vegetative state, and the severe traumatic brain injury. Right, shows multiple MRI shows multiple lesions, punctate hemorrhages. These are involving the white matter tract. So you can see these punctate hemorrhages, right? Um, let's stop here, I guess. Or should we cover the fascias? No, I think we cover the fascias in a separate video.